Well, to introduce the topics, the first thing we're going to talk about is the modified Rodnan Skin Score, which is one of the ways we assess skin involvement in patients with systemic sclerosis. We won't go into too much detail, all right? There is a video from the Spanish Society of Rheumatology that you can access by scanning the QR code shown on the screen. It's a video made by Dr. Patricia Carrera, in which she explains in more detail how to correctly perform a Rodnan, okay? Quick facts. Basically, when performing the technique, we are going to assess 17 body areas. We will measure skin thickening and the extent of that thickening, that is, which areas are affected. It has been shown that this technique has a high correlation with biopsy, histology, and other methods used to measure skin thickening. It's a simple technique. We can perform it during a consultation, easy to do, and honestly, it doesn't take much time to carry out. Also, it's important to note that it is sensitive to change. That is, when we administer treatments, if the patient shows improvement at the skin level, we can quantify it by performing the Rodnan, doing serial Rodnan assessments. Basically, we classify or score the skin based on 4 levels, which are the ones shown here. In the next slide, we'll see a representative example of how each of the scores would be categorized. The maximum total score is 51 points, and it has been observed that the higher the score, the worse the patient's prognosis, as it indicates more extensive skin involvement. When performing the technique, we can use either both thumbs, as shown in the images at the bottom, or the thumb and index finger interchangeably. In principle, the U-star does not differentiate between one technique or another, although I personally tend to use the pinch method more often. Other important aspects to consider when performing the Rodnan: primarily the positioning. How should we position the patient? Well, we can assess them either sitting or lying down, but the important thing is that the patient is relaxed so that the skin is as loose as possible and we can evaluate it properly. All right? It's important to emphasize, especially when the patient is lying down and we're evaluating the lower limb, that the knee should be kept more or less in a flexed position at about 90 degrees, okay? That way, at the very least, the skin remains as relaxed as possible and there's no effect from muscle contraction. How are we going to mark the anatomical area? This is basically the point where there is the most disagreement among professionals when it comes to evaluating the Ronda. We have 3 ways to assess the marking of the skin or to assign a specific score to each body area. We can either choose to give the area the highest score, meaning that if in a specific area most of it is scored as 1 and then there's a part scored as 3, we classify it as a 3. Or we can score it based on the representative area in this same case. All right, if most of the area is scored as 1 and only a small part as 3, the most common approach is to assign it a 1. And then we also have the average, which would be a combination of the two. If we find an area that is predominantly scored as 1 and then several areas scored as 3, then the average would be 2. All right, what does the U-star recommend? U-star basically recommends that we calculate the average, but be careful, okay? It's important to keep in mind that the averaging must always be done consistently. That is, what we can't do is have a patient come in, I perform the evaluation, all right? And at that moment, I think I'm unsure between a 2 and a 3, so I give it a 3. Then the next patient comes in, and I have the same doubts, but this time I give it a 2. Because then, basically, we're not being consistent, and when it comes to evaluations, we could make mistakes, right? More things. Obviously, the score can also vary with age, all right? It is true that as time goes by, as the years go on, the Rodnan, the score can improve, all right? But that doesn't mean there's an improvement in the condition or in the extent of the skin involvement, okay? Basically, the skin gets older because patients with systemic sclerosis, as they live longer, they age too, right? And basically, the skin becomes atrophic, okay? Due to the loss of subcutaneous cellular tissue. This has also been observed, okay? That in limited cutaneous systemic sclerosis, well, when using the Rodnan score, it's not associated with the severity of skin involvement, unlike what we've seen in diffuse cutaneous sclerosis. Nor is it sensitive to changes, so in limited cutaneous sclerosis, it doesn't make sense to use the Rodnan score for evaluation. What other things do we need to consider? Well, obviously our patients are going to have other comorbidities. They may have edema due to changes in circulation, that is due to venous insufficiency or lymphedema or other causes. This is going to affect how we assess the Rodnan score. The truth is that studies have shown there isn't a good correlation, okay? When there is edema, okay? Between the score given to the area and the biopsy, all right? There is quite a bit of discrepancy. There isn't really a specific method or established protocol either. So it's not very clear how to proceed. There's no clear consensus. Although generally it tends to be scored as 0, it's important to remember that this circumstance will affect the score we assign to each skin area. Also, adhered skin, this is important. Rodnan does not measure skin adherence, all right? Adhered skin is generally associated with atrophy, and atrophy is scored as 0. All right. It's true that it's rarely classified as a 3, okay? But that's mainly because, of course, due to the involvement of deeper tissue layers, it sometimes gets confused. All right. And people think it's actually more indurated than it really is. And what about children? Because children can also have systemic sclerosis. Well, obviously, it's important that whoever performs the evaluation has experience with children, all right? Because basically, well, it's a bit more nuanced, a bit different when assessing them. And also, the score we obtain has to be adjusted based on body mass index and Tanner stage. Children's skin is thicker because they have more subcutaneous fat. And as they grow, that subcutaneous fat gradually decreases. And as they also, let's say, mature sexually, obviously that subcutaneous fat also decreases and the scores in children go down. And well, Pablo mentioned it earlier, but it's important to emphasize it, all right? How often do we perform the Rodnan? Well, obviously not less than 3 months. That is, if we do it in less than 3 months, it has been shown that there are no significant differences when scoring the skin areas, all right? Also, some other tips when evaluating these patients. Well, obviously, when we're going to assess a patient we've evaluated before, try not to look at the previous scores, mainly to avoid being biased when evaluating how the patient is doing at that specific moment, all right? And if possible, the patient should always be evaluated by the same professional. It's true that it can be considered at a given moment. This is something USTAR especially mentions, that if it's not possible, then it's not possible. Well, in clinical trials, I mean, it is acceptable for another professional accredited by USTAR to carry out the evaluation. But if possible, it's better for it to be the same person, so that the scoring remains consistent.